Step 3 of Plan A. And again, don't have to do them all in order. But step 3 will likely be after we've done a little bit of analysis and after we figure out what the guiding principles are, because we can't really develop the program. These are just some questions that I'm looking for answers for. These are questions that people ask me. I think the group that's going to get together and come up with how this is going to work have got to be able to answer these questions. Some of these we talked about last time. What should be included in an episode of care? This is not as hard with preschool kids as it was for adults, because adults had a long list of services. Preschool kids have a long list, but we're all pretty used to what it is. It's the have stuff, it's the therapy, it's some consultation with nurses, dietitians, nutritionists, people like that. How long is an episode of care? A year. Most of our stuff goes for a year. For little kids, maybe it's 6 months. The experts will be out in the stakeholder group. Probably not going to be sitting on the 5th floor of Donaghy Plaza North. Does it include early childhood special education? That'll be a big one. Right now, the DDTCSs do that. Like I said, I don't. It's a burden on paperwork. I don't know that it affects the care. I think if tomorrow we said we're not going to see SE providers, I'm not sure everybody noticed a huge drop off in care, but they would. You're always scared of unintended consequences. There's a reason why there's a federal mandate for some type of intervention at age 3 under the IDEA. I would bet when the people from the provider associations and other stakeholder groups get in a room, they'll have a lot more expertise about that than I have. Should the episodes be priced differently based on level of need? There's a school of thought that says you get paid a case mix average. But I can look at the data we have now and see that might not be the same, or it might not be an equitable way of doing things. We might end up, we already talked about one case, it may be that in rural areas where you have to entice therapists, that you got to have some kind of extra in there to pay to get them out there, to get them in a car to come out there. They're also, if you pay one rate and say, well, we figure everybody's going to have some of the 3 therapy kids and some of the no therapy kids, well, that provides a lot of opportunities for gaming. And for somebody to figure out, well, if we take, we move it down, we'll still be getting paid like we were going to have 35 3 therapy kids, but we're really only going to have 33, and that we use that difference to help jumpstart the fund drive for the new preschool. And there's just no reason to have that kind of stuff, I don't think. If y'all can figure it out, do it. Tiers of care will be tough. The therapies are pretty well set. That's something we've talked about using. I'm not going to speculate as to how that's going to come out. That'll be an interesting discussion. Will all providers be expected to care for children with all levels of need? Can you say, let's pretend we already had this discussion and there's 4 levels of care. 3 therapies, 2 therapies, 1 therapy, no therapy. Can somebody say, we're just going to be a 1 and a 2? We're going to do the bottom half. We're going to be a level 1 clinic. I don't know. I don't know how that works access-wise. I'm not sure. Well, I'm not sure. I'm up here stumbling around because I don't want to say I don't like it. But obviously I don't like it. Because even the smallest place, even the most rural place, can do a good job with children who have a lot of needs. We've all seen it happen. So I'm a little worried about saying we're going to segregate people by level of need within these clinics. Will all providers be able to be reimbursed for transportation? That's a big one. CHMSs can't right now. DDTCSs can. They don't have to, and some of them don't. That's got to be resolved. That'll be a big issue. I know there's been a lot of discussion over at Medicaid about the whole non-emergency transportation because it's tough. That's a tough thing to do. Where's Dan? Dan could give you about an hour and a half of how sometimes non-emergency transportation doesn't work that well for our children. And it didn't. I was not happy to read some of the emails he sent me about it. But I also know that it's not a money-making proposition for providers. It's expensive. It's expensive to to maintain a fleet of vans. It's expensive to carry liability insurance on. Those 19-year-olds. Sometimes you have driving them who have 4 speeding tickets. It's expensive. We've got a huge fleet of vehicles. They're expensive to maintain. But I also know that way Johnny gets there and gets his therapy, and you don't have to worry about whether Mama had to work a night shift and her car broke down. That's going to be tough questions for y'all to answer. We got to do it. Now what? There's a now what? There's a bullet point on here we don't have because I didn't know we'd need it till this morning. I think now one of the things we need to do is make sure we work hard to make sure everybody understands what I talked about at the beginning of this. I want people to make informed decisions about what the private option means to all of us, what it means to our families, what it means to us as providers, state included. If people make an informed decision, that's fine. I'm not going to put their posters up in my office and find ways to mess with them. If they think about it and they decide they just can't vote for it, that's okay. But if you get a chance to educate your member of the General Assembly on why it's important to you, do that. That's important because all of that feeds back into how much money is there to operate the Medicaid program, which, as we've already said, pays for everything we do. We've got to work on the successor program. One of the things, of course, is naming it. Well, that's what we just got through talking about the last 20 minutes. We've got to, as an agency, along with stakeholders, do some rulemaking to implement 1017. General Assembly makes the law. The executive branch, that's us, has to apply the law. And then the judicial system tries to find a way in there to make some money. I think Jim's awake. I was trying to make fun of him. So we have to make rules and we have to promulgate them. And that's a lot of work. And we need some help. It's not a huge amount of work. The way Act 1017 is written is pretty well laid out. CHMSs, DDTCS is going to be treated the same. We've just got to go back in our policies and where we just address DDTCS. And in some cases, we treat the adult programs and the children's program the same. We got to separate it out and make sure that our underserved policy applies the same to both groups. But that will take a lot of writing and procedures. Work with stakeholders to determine the best use of resources in the First Connections program. This is one I had a slide for I threw out. We talked about last time, our First Connections program primarily uses their federal resources, they're 100% federally funded, to work with children who aren't clinic-based, who aren't receiving services in a clinic-based setting. Now, there's some overlap, and some of the stakeholders and Tracy and her staff have talked about, well, after we kind of had a long talk about coordinated care, everybody knows that if you're in a clinic-based setting, whether it's a CHMS or a DDTCS, you're getting some good coordinated care for the most part. We have a few problems with that therapy being way over here, in a few cases, not very many, but we're working on that. But the great majority of children, The therapist is right there on top of the classroom. The person writing the plan has access to everybody that's involved in the plan. That's not an issue. What we have talked about is looking at whether our First Connections program ought to focus solely on children and make that do not have that care coordination that happens in a clinic, and make sure that their care is coordinated. I think Mark brought it up earlier, because even though somebody might elect for their child not to go to a clinic, they may still need a lot of care, and they may need that care to be coordinated. Somebody needs to make sure that mom understands what the neurologist said didn't necessarily contradict what the PCP said, or maybe it did, and we got to figure out a solution. So the First Connections program actually has a stakeholder board called the ICC, Interagency Coordinating Council, and we're going to ask that group to look and talk about, is that the best use of those federal resources? Because there's not very much money in the EI program. It's, Tracy, are you still awake? $3 million? $3.5 million? Is it 4.4? I obviously hadn't checked in a while. Either that or you're hoarding money. And that's a lot of money, but it's not $250 million. And so that very limited amount of money, then we need to focus it solely on those children who aren't going to get that good care y'all have. And I know there's people in here who are going to say, now wait a minute, part of that EI money goes as to catch kids who fall through the cracks. And we'll have to have a talk about that. I'm trying not to look at Amy because she's the one that reminded me of that. We got to do those things. Obviously, y'all know how to get a hold of me to give me feedback and suggestions. We got a lot to do, and we still have a pretty short amount of time, because for us to promulgate something, get it through the Procedures Act, get all the changes made, especially in light of all the heavy traffic that's going to be going through Rules and Regulations Committee and Public Health Committee in the next 6 months, we got to get on it. And I need you guys to work as hard on this as you did on the managed expansion thing. And I know you will. And we will help you however we can